Very good evening to all. So today we are going to start with one of the fantastic lecture series which we are continuing, revision for final year MBBS in pediatrics by Dr. Prithiviraj sir. And last time, during his last class, he has covered excellently. We have started with the pediatric cardiology series, and he has excellently demonstrated, he has excellently taken how to approach how to approach the fetal circulation and congenital heart disease. Today, he is going to tell you how to approach a cyanotic heart disease, especially taking into the topic of TOF. So, tetralogy of Fallot and its physiology and its management. Thank you, sir, for joining with us today. And now the session is yours, sir.
I guess good afternoon to one and all. So by continuing our previous class series, which we started last 2 weeks ago, about pediatric cardiology. So today we will be discussing more about that pediatric cardiology approach to congenital heart disease per se. We have a brief discussion last week. Now we will continue with that. Along with that, we will start with approach to cyanotic heart disease. Okay, so last time when we started our class with we ended the class with the approach to the cyanotic heart disease in the neonate. It could be of the child can present with aspect.
Sir, screen is not shared yet, sir.
Wait, wait. I guess
Yes.
now it is visible.
Yes, sir.
Okay, so we will. So now we will discuss these three subtype which we decided last class. We ended with these three syndrome: blue baby syndrome, gray baby syndrome, and pink baby syndrome. So blue baby syndrome is nothing but the cyanotic congenital heart disease, right? Now this cyanotic congenital heart disease. So I already discussed how to differentiate respiratory cause of the cyanosis from the cardiac cause of cyanosis. What is hyperoxia test and what is pulse oximetry test, which we do always the pulse oximetry screening test at the age of 24 to 48 hours of life. And then this hyperoxemia test is mainly useful to differentiate whether the cyanosis is mainly because of respiratory cause or cardiac cause, which I already discussed in detail in our old classes. In Nest syndrome, this is one thing. They can present with cyanosis, where one of our differentials should be cyanotic congenital heart disease, along with the differentials of your pneumonia and respiratory disorders. Whereas when the child present with a gray baby syndrome, it means the color of the skin is gray. That means the circulation in the skin circulation is poor. So most likely the child is in shock. So one of the most commonest differential that has to come in our mind in any neonate who are presenting to your emergency room with the features of shock is always sepsis. You have to rule out sepsis by doing the relevant investigation and start relevant antibiotics, empirical antibiotics. Still, after giving appropriate antibiotic, the child is not improving, then that should knock your mind that might the child may be having some duct dependent systemic circulation or cardiomyopathy or cardiac arrhythmias, which is causing cardiac failure, leading to low cardiac output, and as a result, the skin circulation is poor. So that is one thing which you see when you see some child is in shock. Third one is the child is color is normal, there is no cyanosis, but still the child's work of breathing is more. And when you get a history from the mother is saying the child is having a recurrent respiratory tract infection, and for which the child is getting admitted. So the lung is completely congested. So when the lungs get congested, when there is over circulation. So what are the conditions which can go for over circulation? Most commonly, it's your left to right shunt. Left to right shunt is a acyanotic congenital heart disease. Most common disorder which is seen in our country is your ventricular septal defect. So that should also come in your mind when you see some child with a recurrent respiratory tract infection. That is known as pink baby syndrome. So we divided we divided this approach to congenital heart disease in a neonate as a blue baby syndrome, the gray baby syndrome, and pink baby syndrome. So accordingly, we can decide what could be the possible etiology, differential diagnosis, and how to manage. So it is a simplistic, simple way to approach any baby with a congenital heart disease, not cyanotic. It could be any congenital heart disease. It could be cyanotic, acyanotic. So already I said. Um, so blue baby syndrome and the scenario I already told. What are the scenario? Respiratory and respiratory causes and cardiac causes. So the respiratory causes, how to differentiate. The respiratory retraction will be more common. So when you see this, the cyanosis will not be that much significant in case of a respiratory cause. It will just mild. Whereas compared to the distress will be markedly the respiratory distress you can observe. Whereas cyanosis will be mild. And when you give oxygen support to the child, or when the child cries, the cyanosis decreases, and that's improve in the saturation when if it is a case of respiratory cause. Whereas in the case of cardiac cause, there will be no improvement. And when you do a blood gas analysis, mainly a PCO2, PaCO2, so in case of ventilators problem, when there's a lung parenchymal disorder, both oxygenation and ventilation get impaired. So both oxygenation and ventilation getting impaired. So that's the hypoxia, that is your low PaO2, but that's the carbon dioxide retention. That's where your PaCO2 will rise. So ABG analysis will show increased PaCO2 in the case of respiratory cause, whereas in the case of cardiac cause, it should be a wait a minute. Okay. Um,
Yes, sir, it's visible now.
okay, okay, okay. Okay. So the PaCO2 will be rising in the case of a respiratory cause because the ventilation is not happening because that's a parenchymal disorder. Whereas in a cardiac cause, your lung is normal. It's the only problem in your heart. So your PaCO2 will be near normal, right? And when you do the cardiovascular examination, presence of murmur, abnormal X-ray, raised BP, these are the things you will see in the cardiac cause where it will be normal in the respiratory cause. So this is the how to differentiate the cyanosis because of a respiratory cause or a cardiac cause. So what is this about hyperoxia, which I already designed? Now hyperoxia is something which is initially done to rule out whether the child is having a respiratory disorder or it's a cardiac disorder. Among cardiac disorder, what could be the possible cardiac disorder? We get an assumption with it, but the diagnosis is always by doing the definitive investigation, that is a 2D echocardiography. So in the hyperoxia test, what we'll do before giving it, hyperoxia means what? You're giving oxygen. So hyperoxia, so more oxygen. So you have to give oxygen. So before prior giving oxygen to the children, what you do, you do a ABG of the child, and also to know PaO2, baseline PaO2, and also the SpO2 by your pulse oximetry. Now, so you get some value, right? Now, after that, for 10 minutes, you're going to give 100% oxygen, FiO2, via nasal cannula, by any machine, what you are giving, with any respiratory support the child is having, you are giving 100% FiO2. After this, you have to go to do again a repeat ABG, and also the SpO2 you have to see. Now, so you have a four scenario here. What could be the possible? One is the FiO2 after giving effort, SpO2 become 100%. Okay, 100%, it is more than 100%, and PaO2 is more than 300. 150 to 300 PaO2 in second scenario, and SpO2 is 100%. SpO2 is less than 91% to 93%. Here also less than 91 to 93%. And FiO2 here under to FiO2, SaPaO2 is under to 150 mmHg. In another case, you have less than 100 mmHg. So the point is this. This is the difference. This most likely a respiratory cause. The first two scenario where the SpO2 is 100% after giving oxygen to the child, and the PaO2 is more than 150 to 300 in second scenario, first scenario more than 300. In this both the scenario, okay. In okay, in both the scenario, what happened? This is most likely a less likely a cardiac cause. Okay. Just rule out cardiac cause. More than 300 or more than 100%, more likely is less likely a cardiac cause. And this may be most likely a case of respiratory disorder. Second scenario. But about the third and fourth thing, one is for third thing where the saturation is under to 150. So 91 to 93, less than that. And PaO2 is under to 150. Most likely it is a condition where you have a PPHN. It's most common, that is persistent pulmonary hypertension, which we'll be discussing in the subsequent classes, which we'll be discussing. And less than 91 to 93, less than 100% is typical case of the congenital cyanotic heart disease. So yes, in both these two cases, CCSD is likely. So that is the reason of doing hyperoxia test. By this hyperoxia test, you can delineate, as you have good way of delineating the cause of cyanosis, could be of respiratory etiology or cardiac etiology by doing this hyperoxia test, right? Now, the point is, now another one question is the rationale of doing hyperoxia test, whether it's indicated or not. So in previous classes, when we were discussing of this prostaglandin, yeah, we will be discussing prostaglandin in one. This will be discussing. The point is that when you do a ductus dependent circulation, when you have a ductus dependent circulation, what is meant by ductus dependent circulation? Ductus dependent circulation is that so we have two types of circulation. We have one is systemic circulation. Okay, again this one. Okay. The hyperoxia test. So when you have a ductus dependent circulation, what is meant by ductus dependent circulation? So as you know, our circulation is a series circulation. So you have a systemic circulation, pulmonary circulation, right? Now this two circulation has to get the blood from the respective chamber. So systemic circulation will get the blood from your left ventricle, that is right from the left heart, and the pulmonary circulation will get the blood from the right ventricle. So whenever there is some indifference in this pathway, so there must be some alternate pathway which the body tries to use so that the circulation is established. So in case of any indifference in the systemic circulation, the ductus arteriosus remain patent, so it will bypass the blood from the pulmonary circulation. The blood that goes to pulmonary circulation will also enter the systemic circulation, since the pathway to the systemic circulation in there. Like for the example, you have a critical coarctation of aorta, critical aortic stenosis, hypoplastic left heart syndrome. So they are the where your left ventricle is unable to pump blood out to the aorta into systemic circulation, where the ductus arteriosus has to take role of has to take in charge, so that some of the blood it can send to the systemic circulation. Despite that this is an deoxygenated blood, but some amount of blood reaches to your systemic circulation so that the child may survive for few time. For few time till the definitive surgery is done. Same to the case of drug dependent pulmonary circulation. When these both are not going to occur, because so your your duct should be, so for this two to happen, in case of drug dependent systemic as well as drug dependent pulmonary circulation, you should have a patent ductus arteriosus. So patent ductus arteriosus is mainly because of presence of hypoxia. If there is an oxygen, when you're giving more oxygen, you are going to close this duct. That's the reason when you are suspecting any congenital heart disease and you are suspecting it is duct dependent, never do an hyperoxia test. But by giving hyperoxia, you're going to close the duct. So increase the it will causes the impairment in the circulation, the alternate pathway, and it will lead to more of cyanosis in the case of duct-dependent the pulmonary circulation, and more of shock in the case of duct-dependent systemic circulation. So these are few things which we'll be discussing as we go on. What are the causes of this cyanosis? Is cyanotic blue baby syndrome. One is your increase in the cause of congenital cyanotic heart disease in newborn. One is decrease in the pulmonary blood flow, mainly your duct-dependent pulmonary circulation, which I already did. What are the example? Hypoplastic right heart syndrome, namely your tricuspid atresia with pulmonary stenosis, severe upstream anomaly, severe TOF, critical pulmonary stenosis with pulmonary atresia with intact IVS, and then variable pulmonary blood flow. Yes. Yes. Oh God, this is sorry for the interference because of this technical glitches. Okay, so one is decreased pulmonary blood flow, which I already discussed about the hypoplastic right heart syndrome, and also your severe Epstein anomaly with severe TOF, PS, critical pulmonary stenosis, pulmonary atresia with intact IVS. These are a few examples for decreased pulmonary blood flow. Whereas the variable blood flow, pulmonary blood flow is there, but it's variable. That sometimes it's increased and also decreased. This is your administered physiology, which we will discuss. One of the classical example for your administered physiology is your truncus arteriosus and total anomalous pulmonary venous circulation and parallel circulation with pore mixing. So you have a transposition of great artery with intact IAS and IVN. We have an intact intra-arterial septum, intraventricular, so that's a pore mixing. So that we will also call cyanotic heart disease. And that is obstruction to the pulmonary venous flow. That is, there might be a mitral stenosis or there's a pulmonary venous obstruction. These are the few examples for the congenital cyanotic heart disease, which I told it as a blue baby syndrome. Now, what about this low hypopolymorphism? That is your gray baby syndrome, which I already discussed. Either always they present in the features of shock. You will always get the shock features. What are the features of shock? You will have a raised CRT, steady pulses, cold, calm skin, decreased urine output, altered sensorium, mottled skin. In the late phase, you will have hypotension. So whenever you see this kind of features in a baby, you will always have to rule out what you have to always rule out sepsis. By doing all relevant investigation, you start an antibiotic. Still the child is not improving. Still not improving. Go do echo because it either could be a duct dependent systemic circulation, one of the most important differential. What are the duct dependent systemic circulation you know of? Your critical congenital, critical coarctation of aorta, critical aortic stenosis, interruption of aortic arc. These are the the most important cause on hypoplastic left heart syndrome. So these are the four important cause of duct dependent systemic circulation. Another is your cardiomyopathy and cardiac tachyarrhythmias. Cardiac myopathy, tachyarrhythmias. So these are the few examples how to approach any case of gray baby syndrome. Okay. So what about this hyperperfusion, which already pink baby syndrome? I saw all the left to right shin. They will present as recurrent respiratory tract infection. This is not. Okay. Okay. Sorry for the technical glitches. So third scenario, which I already discussed, what is pink baby syndrome? Mostly it's because of a left to right shift. For example, your BSG, PDA, and your AHG. You have a recurrent respiratory tract infection kind of presentation where everything is normal. The child color will be pink, there will be no cyanosis, but that's a recurrent respiratory tract infection because of pulmonary congestion, because of the pulmonary over circulation, which is mainly because of left to right shift. Most common cause of the left to right shift in our country is always a ventricular septal defect. So these are not that much important. So a few things which you should know in any neonatal echo or neonatal thing case, what you have to see. One is your on investigation when you see that cardiac examination at first aid, apex it's always right ventricle apex beat. Neonate for first few weeks to few months, you have a right apex dominant. The reason I already told in the fetal circulation, because the right ventricle has to work hard to overcome the pulmonary vascular resistance, which is high in the in utero period compared to a extrauterine life. As a result, the right ventricle is more muscular compared to the left ventricle. As a result, the child will have a right ventricle apex dominant for few months of their life. So, whenever you do an ECG for the children in neonate, you'll always have a right axis deviation or right axis right dominance. This is more common. This is very common in a neonate period. If whenever you say a left ventricle apex dominant in a case of a left axis deviation in a neonate, it is not normal, it is abnormal. The most common cause of left axis deviation, there are many other causes, but as a UG and for the PG resident, you have to know more about that. But as a UG and intern, you should know what are the causes of the left axis deviation. One of the main causes is your tricuspid atresia. So whenever there's a tricuspid atresia, the child a pattern of changes that happen where the left atrium, left ventricle will be more dilated. So the passage of current through the left atrium, left ventricle will take more time. As a result, there are deviation toward the left atrium, left axis. That's known as left axis deviation. The most classical example for left axis deviation in a neonate is a tricuspid atresia that has to be ruled out. And when you do the parasternal impulse, it is normally seen in neonate number. And when you do a arch sound, S1, S2, S3, S4, S2 is very important as a undergraduate, as well as in your medicine, as well as in pediatric, as for PG resident. The sound of S2 has a very important role in diagnosis wide variety of cases, which we will be discussing in subsequent sections of the classes. If you have a normal S2, one thing you should learn, if you have a normal S2, when you can hear or you can appreciate A2 and P2 separately, then the critical congenital heart disease is ruled out. S3 and S4, if you are seeing S3 and S4 in a neonate, it's always a gallop rhythm. That is, the child is going for a heart failure. So most likely it could be a cardiomyopathy, dilated cardiomyopathy, or because of a you load into left atrium, left ventricle, and we may increase left to right shunt. That will be like the VSD, or that severe pulmonary vascular resistance, pulmonary hypertension. As a result, the heart go for failure. The murmur, normally you should know this point. The most of your congenital cyanotic or any congenital heart disease, very rarely you can appreciate a murmur during neonatal period. So that means absence of murmur doesn't rule out congenital heart disease. You have to see other features such as the for congenital heart disease. There may be cyanosis or there may be single S2. So these are a few things which you should note very carefully if you are suspecting congenital heart disease, because in most of the cases, you don't see a congenital heart disease. Don't see any murmur in a congenital heart disease. And another thing, whenever you have a loud murmurs, that is always a obstructive lesion. So because of some obstruction only, you will have a loud murmur. And regurgitation murmur like MR, TR, you can see regurgitation murmur. And also the non-cardiac causes of murmurs should also be taken in mind. What are the non-cardiac causes of a tricuspid regurgitation in a neonate? One is most important thing is a PPHN. What is this PPHN? Persistence of pulmonary hypertension. That is the persistence of your fetal circulation, which we have already discussed in the previous fetal circulation. What is this PPHN? A brief account I have already given. So I'm not going to do in the details. The detail will be covered in the other subsequent classes. Another one is MAS, that is your meconium aspiration syndrome. And third one is iron membrane disease. It's not. I think it's okay. Okay. So these are the three causes of non-cardiac causes of tricuspid regurgitation. One is persistent pulmonary hypertension. Second is MAS, what is mass, meconium aspiration syndrome, and iron membrane disease. And diastolic murmur, as we know, diastolic murmur in neonate as well as children is always pathological according to a NADA's criteria. So, what are the few examples like TOF with absent pulmonary wall, aorta to left ventricle tunnel, and tricuspid atresia with truncal wall regurgitation. These are few examples for diastolic murmur in a neonate. ECG, as I already, is always a right ventricle hypertrophy with RAD, which is a common thing. And chest X-ray is that there is no role of greatest role of chest X-ray is always to rule out pulmonary cause of cyanosis. So what is the main role of chest X-ray? Not to see cardiomegaly, because apparent cardiomegaly as such you will be seen in AP view. The main important role of chest X-ray is to rule out pulmonary cause of the cyanosis and also to know the pulmonary blood flow, whether that's a plethora or there is an oligemia. So these are the two things which you have to rule out by doing the chest X-ray. So what is it? Most important thing is echocardiography. So all congenital cyanotic or any congenital heart disease, echocardiography has the main role, right? Echocardiography is one of the important investigation that has to be done to rule out any form of congenital heart disease. This is the standard of care or standard investigation or investigation of choice, whatever. This should be done in any case of suspected congenital heart disease. So I already told about the oxygen role of oxygen. So whenever you are suspecting any duct dependent circulation, right? It could be duct dependent systemic circulation, or it could be a duct dependent pulmonary circulation. So whenever suspecting the duct dependent systemic actual pulmonary circulation, now this duct has to remain open so that the blood, in case of this is the arch of aorta, and that is going to descending aorta. This is your pulmonary artery. In case of duct-dependent systemic circulation, your blood flow in this way. In case of duct-dependent pulmonary circulation, your blood flow in this way. For that, your patent ductus arteriosus must be open. Should be patent. The patent is mainly because of hypoxia. That's the reason. In any case of duct-dependent circulation, it could be either a systemic or pulmonary. The targeted PSPO2 will be 80 to 85%, not more than 85%. This is the target. This should be for a practical purpose. We should not be go and jump that I have to make the circle at saturation to be more than 94, 92%. We do this because we don't know the actual logic behind of the keeping this saturation. The reason is this ductus which we have planned. This ductus should be patent for both systemic and pulmonary circulation dependency. So this percentage, when you have this percentage, 80 to 85%, this related to hypoxia helps in the maintenance of the patency. So when you try to keep the saturation more than 85 or more than 90, now the patency is going to affect it because hyperoxia will stimulate the muscles of the pulmonary arteriosus to contract and leading to the closure of the pulmonary ductus arteriosus. The ductus arteriosus muscles are highly reactive to the oxygen. So when you go more oxygen, the ductus arteriosus will get constricted. As a result, what happens? It will close, right? It will close. So when it get closed, what happened? The blood flow will not happen. So in case of duct dependent cyanosis, pulmonary circulation, there will be more cyanosis. The cyanosis intensity will increases, and duct dependent systemic circulation, which will depend on the duct, will become the child will become more and more shocked, and which cannot be corrected because we have closed the ductus arteriosus by giving more of oxygen. That's why the target oxygen should not exceed 85% in any duct dependent circulation. This is one practical point. The PG residents as well as interns should know when you are seeing any circulation, any children with suspected cardiac lesion, congenital cardiac lesion. So I already said one way of keeping the patency of ductus. Uh, sorry, as I already said, one way to keep this. Is it visible? So to keep this pattern ductus arteriosus pattern, one is keep a target oxygen of 80 to 85%, not more than that, or else ductus arteriosus closer. And another one, this one drug which you use for any suspected congenital heart disease in neonate is your prostaglandin, because you know in utero the prostaglandin E2. This is one of the famous question anyone can ask. Not famous, it's a tricky question. Tricky. This fact based one. Okay. Okay. Yes, yes, okay. Okay, the question was which one is your hypoxia state, which keep the patency of your ductus arteriosus. Another one important thing is your hypoxia, so that's why we are keeping that oxygen in the form of by 80 to 85 percentage of target SpO2. Another one is your prostaglandin. This has to it's the level of prostaglandin should be higher to keep this ductus arteriosus open. But what happened in utero? Your prostaglandin E2 play an important role in the patency of the ductus arteriosus. But as the child is born, ex utero, the thing which you give is alpracidol, and alpracidol is PGE1. So this should be kept in mind, which is very we will easily go confused. So E2, PGE2 for in utero, and E1 ex utero, it's a PGE1 which we give as a thing. So let's have a small details regarding this prostaglandin and uh, so now as per recent guidelines or any other thing, when you see the prostaglandin is boon to congenital cyanotic heart disease in acute management. So whenever you see any child with persistent cyanosis, persistent thought not responding to the routine management for a respiratory distress syndrome as well as for a shock, like you are suspecting sepsis, despite that the child is not improving, you have always keep this cyanotic congenital heart disease in your mind. And in most of the cases, the ductus arteriosus play an important role in keeping the circulation intact so that the survival of the unit is possible. If that is not going to happen, the child will succumb to the condition. That's the reason why ductus arteriosus has to keep open, but it will be open for first 72 hours of life. But after 72 hours of life, there are some physiological changes that happen in our body which causes the closure of the ductus arteriosus. In order to overcome that physiological changes, we have to give something from outside. What is that? That is your prostaglandin. So that's why it is given. The duct-dependent circulation will always present when the ductus closes. So PG even administration reopens or maintains the patency of ductus arteriosus. But the point is, now giving a PGE1 is not only going to open up the ductus arteriosus, it will also cause vasodilation in many other parts. That's one of the side effects of the giving ductus arteriosus. But the volume or the percentage or the concentration of prostaglandin even that is required to keep this open, to keep this ductus arteriosus open is so minimum that the systemic side effect is always diluted. So most of the time, the systemic side effect is not seen because of the minimum dose that is required for keeping this ductus arteriosus open. So why it is very important? Because most of the children are born in a center where your proper tertiary cardiac care is not available. You don't have a cardiologist, intervention cardiologist, CTBS surgeon. Most of the delivery happen in a district hospital or any primary health center or any medical college hospital without cardiac facility. So in order to refer the child, you have to stabilize the child. For stabilization, always your ductus arteriosus should keep open. So the minimum mantra we have in our hand to keep this saturation at around 80 to 85 percentage. And another one is by supplying prostaglandin so that it will keep the patency of the ductus arteriosus till the child reaches a referral center where the definitive cardiac procedures can be performed. So what happened when you give a prostaglandin E2 to a person with a duct-dependent pulmonary circulation? So when you are suspecting a duct-dependent pulmonary circulation, they will have a intense cyanosis. After giving prostaglandin, what are the changes you will be seeing? One is that's the improvement in the PO2, that is 20 to 30 mmHg. Within few minutes of giving, you have improvement of PO2 from the baseline from to 30 mmHg difference, and the correction of hypoxemia and acidosis will happen if it's a duct dependent system, pulmonary circulation. In the case of duct dependent systemic circulation, after giving prostaglandin, the aortic blood flow increases. As a result, there will be more of the increase in the hypertension will be corrected, the BP will raise, and the perfusion to other organs will increases, leading to lower limb will get more blood, and there's an increase in urine output, and the metabolic acidemia decreases, and also the child's sensorium will increases. So this all are the indicated that by giving this prostaglandin, the circulation has been improved because you are keeping the patent ductus arteriosus patent. But for TGA, when you go for TGA, the transposition of great artery, the main important of great artery, it's not your patent ductus artery. Ductus artery is not going to have an important role in the keeping that circulation for having a appropriate mixing of blood. Cannot happen in a ductus arteriosus in a TG lesion. We always want a arterial level shunt. So for making this arterial level shunt by using balloon atrial septostomy, before that, the child has to be stabilized. The acidosis should be corrected. For that reason, we have to keep the ductus arteriosus patent. The ductus arteriosus is not the primary shunt which we want in a TGA. It is an arterial shunt which is very important because the bidirectional shunt will happen only in arterial in the atrial shunt compared to the ventricle as well as the ductus arteriosus in a TG lesion. We need a bidirectional shunt, not a unidirectional shunt. That's the reason we need an atrial septostomy in the child with suspected TG. So for that, in order to do that, you have to stabilize the child. For stabilizing, we give a PG-given infusion so that the ductus arteries is kept open, the child is stabilized, and you do a BAS. After doing BAS, then the definite procedure of atrial switch is performed in a TG. What is the dose? That the dose of this is here. Recommended dose is 0.05 microgram per kg per minute. So dose is 0.05 microgram per kg per minute. This is the required dose that is required prostaglandin E1 for any child with suspected case. What are the side effects? One is I already said because this prostaglandin E1 not going to act only in the uh, ductus arteriosus, it will also act on the systemic circulation. So there will be systemic vasodilation. So they may present with hypotension. When there is an hypotension, always treat it with IVF with inotrope. And most common complication that is affected by the administration of PG even is apnea. This is dose dependent. So for these cases, don't stop the drug. Instead, you just titrate the dose to the bare minimum where apnea is not going to happen, and also your ductus arteriosus is kept patent. Another one, fever, because prostaglandin, already know prostaglandin will cause fever by acting on a hypothalamic thermal regulation. And then when you give a prolonged administration for more than 5 or 7 days, what happens? Same thing, it will cause vasodilation in other vessels, capillaries, arteries, systemic circulation. So when the capillaries get vasodilated, the permeability increases, leading to capillary leak syndrome and tissue edema. And ductus arteriosus also, we are keeping this patent arteriosus patent, ductus arteriosus patent for a long time. Just beneath this ductus arteriosus were left bronchi. So when the left bronchi, what happened? The ductus arteriosus get dilated so much that more amount of blood is passing. So this become hugely dilated. Because of the dilated ductus arteriosus, it will impinge the bronchi, left bronchi. So because of impingement of left bronchi, that's a collapse of the left lung. So left lung collapses because of the dilated ductus arteriosus will compress the left bronchi, leading to blood will flowing to the ductus arteriosus, so pulmonary overcirculation as a result of the pulmonary edema. And one of the rarest complications where prostaglandin induced cortical hyperestosis. For how long you can use prostaglandin? Till the child is stabilized and till the child has reached the referral center where the definitive cardiac procedure can be performed. Till that, we can use this prostaglandin even. The maximum day they are saying is for 5 to 7 days. The practical aspect of prostaglandin is mainly for postgraduates. So when you are suspecting is a drug-dependent systemic circulation and for a drug-dependent pulmonary circulation. When you have drug-dependent systemic circulation, so the funda is they have a normal pulmonary circulation. So the pulmonary blood flow is good. Whereas the systemic circulation is impaired. So from pulmonary circulation, you have to bypass this blood. Again, this is happening. Okay. So in case of drug-dependent systemic circulation, in drug-dependent systemic circulation, you have a normal pulmonary circulation. But the systemic circulation is impaired because of the following reason, which I already explained. In order to maintain this, there must be some circumventing of blood from the pulmonary circulation with this shunt called as ductus arteriosus. I have to keep this patent open, for which I am using your prostaglandin. And you should know this prostaglandin E1, the metabolism happens in the pulmonary vessels, vasculature. Metabolism pulmonary vasculature. Right? Right. Wait a minute. Okay. 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 So the pulmonary okay. So the PG1 metabolism happens in the pulmonary vasculature. So in case of a duct-dependent systemic circulation, as you know, that's a normal pulmonary circulation. So if whatever prostaglandin E1 is going to be given, this will be highly metabolized. So the dose required to keep the ductus arteries open in a ductus-dependent systemic circulation is more since your pulmonary circulation is normal. So dose required to keep a ductus-dependent systemic circulation will be more compared to a case where that's a ductus dependent pulmonary circulation. Here, you have a systemic circulation is normal, right? But the pulmonary circulation is impaired. But for that, right? So you want the ductus arteriosus to be open. And for this, since the pulmonary circulation is impaired, so the prostaglandin E1, whatever you are giving, it's not going to go more into the circulation as it's already impaired. So the metabolism will be low. So there will be low metabolism. So there is no turnover rate is also low. So the to keep this ductus arteriosus patent in a case of a duct dependent pulmonary circulation, the dose of PG1 will be low. So this panda you should know. In a duct dependent systemic circulation, where you have to keep the ductus arteriosus patent by giving prostaglandin. Since the pulmonary circulation is normal in that case, there is more metabolism of whatever prostaglandin E1 you are giving. So the dose required to keep the patency will be more in a duct-dependent systemic circulation compared to a duct-dependent pulmonary circulation. The last point which you should know, what are the conditions where PG even is contraindicated? What is prostaglandin is not indicated? As per the dictum, as per a practical point of view, all the congenital heart disease, whatever be the congenital heart disease, it could be a cyanotic, critical congenital cyanotic heart disease, admissive physiology, transposition great artery, whatever. You don't know the diagnosis. But when you are suspecting any congenital heart disease, presenting at neonate and you think it's a critical, you start prostaglandin E1. There is no hard and fast rule that for this condition I have to give, for this condition I have not to give. I say kuch hard and fast rule, there is no hard and fast rule. For every child, when you are suspecting a congenital critical heart disease in a newborn period, in a delivery room or in your NICU setup, start prostaglandin E1 without thinking before you do an echocardiography, because you have to stabilize the child so that he can survive, so that you can do echocardiography and do a definitive procedure. But there are few indication, there are few indication where this is contraindicated, because as I already said, there are few lesions where the other shunt is very important compared to the actual shunt. The ductus arteriosus has no role in any shunt in those conditions. There is your atrial septum. So there must be an equidirectional shunting that has to happen, and it's only possible in the atrial septum. So you need an atrial septal defect or patent foramen ovale rather than a ductus arteriosus. So in that condition, giving prostaglandin E1 is not going to help much. So these are the these are the conditions where you should be avoiding. So these are theoretical, but practically for all congenital heart disease, suspected congenital heart disease, go with prostaglandin E1 without any second thought, even before diagnosis, so that you can stabilize the child, so that you will stabilize, so that you have time for further investigation and definitive management. So what are the conditions? We will just name it, and for today we will end this class because I have some technical issues here. So because of that, lots of time this is closing. So TOF is your to take. So with this, I'm winding up. The last question for the day is: what are the indications? What are the conditions where PG even is contraindicated? So with that, we will wind up the class. TAPVC, transposition of, TAPVC is, what is this TAPVC? It is nothing but your total anomalous pulmonary venous circulation. Another one is TGA with restricted ASD. This are the TGA, tricuspid atresia, and HLS. They have restricted ASD and restricted PFO. Now, this ASD and PFO, they must have an atrial level shunt for a proper channeling or proper mixing of blood. TGA, tricuspid atresia, and HLS, they require atrial shunt level shunting, so that there is the proper mixing of blood. So proper mixing of blood occurs, and you can stabilize the child rather than a ductus arteriosus, because it is not going to have any benefit for this particular lesion. And in TAPVC, most of the TAPVC, what happened? TAPVC is a total anomalous pulmonary venous circulation. So where it drains, it all drains in your right atrium instead of left atrium. So whatever blood that is you're going to have it in the pulmonary, the oxygenated and deoxygenated blood get mixed at the level of pulmonary artery. Sorry, not pulmonary artery, at the right atrium. So from right atrium, you have to come to the right right atrium to left atrium, which is a simple way to accommodate the blood. So here also you require an arterial septal atrial level shunt instead of a ductus artery. Ductus artery is lying back. So if you want a ductus artery level of shunt, pass atrium right atrium, right ventricle level of shunt. Okay, if you have to go to right atrium, right ventricle, and then it has to pass by a pulmonary artery, and from pulmonary artery, the shunt ductus arteries to the aorta. Aorta, right? So if this is going to happen, the heart has to work a lot. But there is a minimum work which has been done by shunting the blood from right atrium to left atrium. So where you want a shunt at the level of AAC instead of PDA, ductus arteriosus. So these are the four lesions: TAPVC, TGA with restricted AAC, tricuspid atresia with restricted PFO, HLS with restricted PFO. These are the four conditions where prostaglandin has no role or contraindicated. But in TAPVC itself, except infradiaphragmatic obstructive TAPVC, all other TAPVC is contraindicated. But infradiaphragmatic obstructive TAPVC, why it is needed? So this is the reason. But in the case of intracardiac TAPVC, the blood flows by the common this chamber, common pulmonary vein. They will form a common chamber. This common chamber is formed at the level of, you have to know this. This is the only thing I have to say. All this pulmonary veins will go like this. Sorry, again this is happening. I think I have that picture. I wait a minute. I will show the picture and then I will wind the class today. Yeah. Now see. So this is a thing which again. Okay. So this is the thing. So in case of intracardiac TAPVC, there will be a common vein, will be common chamber. Sorry. That's a common chamber will be formed. This common chamber will pass to the esophageal opening in the diaphragm, and then they will pass to the portal vein, right? Then to the hepatic vein, and then they will drain into the IVC. So they drain in the IVC. Whereas in the supracardiac TAPVC and infracardiac TAPVC, they will infracardiac via your sinus venosus and coronary sinus, sorry, sinus venosus, coronary sinus, and supracardiac via SPC. But your infracardiac will drain into IVC via this pathway. But in this pathway, to keep this patency uh, for the blood flow, you require some other thing because this hepatic vein to portal vein connection, there's one thing called as ductus venosus. In these cases, when you keep the ductus venosus open, more blood flow will happen to the heart, TPVC, so that more blood flow will pass to the right atrium, and that to right atrium to left atrium shunt will happen. If this ductus venous is not kept open, the blood flow to the right atrium will be minimized. As a result, what happened? There is no blood flow to the right atrium, so there is no blood flow to the left atrium also. So the systemic circulation will not happen. So to keep the ductus venosus patent, only the infracardiac TAPVC, we use prostaglandin E1, whereas other TAPVC, there is no need of using prostaglandin E1. So only four conditions where prostaglandin E1 is not indicated. One is TAPVC, except your infracardiac type of TAPVC. Second one is TGA, HLS, tricuspid atresia with restricted AAC or PFO. So these are the four lesions which you should remember in a case where prostaglandin E1 is not indicated. So with this, today we are winding up the session. Actually, our point was to start TOF physiology. But before that, I wanted to give an explanation to tell brief about this topic of approach to a cyanotic approach to congenital heart disease per se, which I already discussed previously. And again, I given a somewhat more detail of what is blue baby syndrome, what are the conditions associated with blue baby syndrome, what are gray baby syndrome, and what are the pink baby syndrome, and approach to congenital heart disease, and what are the cardiac examination which is required to perform in any child suspected with congenital heart disease. and also the use of oxygen and prostaglandin in the in stabilizing the child before the child is referred to a proper cardiac center where definitive cardiac procedure can be performed. And finally, we discuss the what are the contraindication for the prostaglandin E1 and why. So with this, we will wind up. So I'll complete the class for today's. Thank you.
Thank you, sir. Thank you so much. It was really a really like a comprehensive and crisp session. Hope so that I request the students to see both the classes, like previous one as well as this one, to have a great good idea about what we are like discussing. And students, so those who are from 2021 batch, those who are entering into final year, so these classes are going to be covering the basics. So I request you to like follow from now on. And those who are in the edge of writing your exams, kindly see these classes as well as the previous year classes of Dr. Prithiviraj sir, where we have covered the growth, development, and some part of nephrology, cardiology, and CNS. We have covered some parts through different classes, so you guys can also see that to have a good idea. And once again, I thank sir for joining with us today. Let's meet in a wonderful session next Sunday.